now.
That's okay.
Just go ahead. Okay. Okay, so our disorders of the stomach and upper small intestine, we have gastritis, which is what we'll start with, and then peptic ulcer disease, which includes gastric ulcers, duodenal ulcers, and physiologic stress ulcers. So we're going to start with gastritis. So this is inflammation of the gastric mucosa due to the breakdown in the normal gastric barrier. So what you want to remember with gastritis is it's inflammation. It can be acute or chronic, it can be localized, or it can be spread over a wide area. So your mucosal barrier, like we said before, protects from hydrochloric acid and pepsin. And when your mucosal barrier is broken down, the hydrochloric acid and the pepsin can come back and irritate your mucosal lining. Some of the causes of gastritis, you've got drugs like aspirin, steroids, and NSAIDs. Those are your Advils, Motrins, and Aleve. A diet can cause gastritis, a diet full of spicy, irritating foods and alcohol consumption. You have microorganisms like H. pylori, Salmonella, Staph, and then other bacterial, viral, and fungal infections. Radiation and smoking can be causes. And then there are also pathophysiologic considerations like burns, hiatal hernias, physiologic stress, reflux bile, pancreatic secretion, sepsis, shock, and renal failure. H. pylori, I don't know if you guys know much about it. It's a bacteria that damages the mucus that protects your stomach and small intestine, and we'll talk more about it as we go. So gastritis, it's inflammation of the gastric mucosa. What causes it? Your drugs, your aspirins, your NSAIDs. Diet, spicy foods, alcohol.
I believe this is table 4212 in your book.
Yes.
If I have it.
1013. Well, is this do they have the 9th edition?
I don't know.
Okay. It's page 941. Radiation and smoking are another cause.
If this is in your Lewis book. Oh. Lewis.
Acid reflux, stress, burns, and shock are also causes. So you've got clinical manifestations. Acute gastritis can cause epigastric tenderness, a feeling of fullness, anorexia, nausea, vomiting. Acute episodes can cause hemorrhage. It's usually self-limiting. It can resolve on its own. And does this go to acute first, or does it go to? Okay, so acute is going to be self-limiting with epigastric tenderness, a full feeling, anorexia, nausea, vomiting, hemorrhage, and then we'll go back to chronic. Ugh. All right. So chronic is similar to acute, but what you want to remember with chronic gastritis is you're losing your intrinsic factor, which is going to result in your vitamin B12 deficiency, and that's because the parietal cells become depleted over time because this is a chronic issue. So when you don't have enough vitamin B12, it's going to result in anemia. So like on your CBC, you're going to see anemia, but we'll get there. Maybe that was too soon. So, skip through that. Chronic is similar to acute, but like I said, the major thing is going to be your loss of your intrinsic factor, your vitamin B12 deficiency. because it's a chronic, it keeps on going, so your parietal cells are being damaged. Do you need me to leave that up for a second? Okay. Okay. And there's your anemia from the vitamin B12 deficiency. So your diagnostic studies that you would want to do, we're going to get a history of drug and alcohol use. Again, your ASA, your NSAIDs. They can do an endoscopy with a biopsy to check for H. pylori. That's your golden standard? Do they need to know? Okay. So your golden standard for gastritis is going to be the endoscopy with a biopsy for H. pylori. Radiological studies aren't helpful because the superficial is generally not involved because this is all the way in where the mucosa is. Like I said before, a CBC may show anemia from blood loss or lack of intrinsic factor. And then H. pylori, they can test breath, urine, serum, or gastric tissue. And the endoscopy would be where they do the gastric tissue. And then your gastric analysis test measures contents of a fasting person for acidity, appearance, and volume. So diagnostics, a history of drug and alcohol use, your endoscopy with your biopsy to test for H. pylori, your CBC to check for anemia because of that vitamin B12 missing intrinsic factor, and then stool for OB. And then gastric analysis to check for hydrochloric acid levels. And then, like I said, x-rays aren't helpful because x-rays really only show superficial issues. So here's your management of acute gastritis. We want to do frequent vital signs. We want to eliminate the cause, if it's meds or if it's something else. Supportive care if they're having nausea and vomiting, fluid and electrolyte replacement, NG tube for lavage for severe cases. And then this is your drug therapy. There's a really good table on page 934. It's 4210. So the point of drug therapy is to reduce irritation and provide symptomatic relief. You've got antacids, which antacids raise your pH, so they make it a more alkaline environment. And they do that by neutralizing the hydrochloric, I can't say that word for some reason, hydrochloric acid.
I can't say a lot of words.
HCl is what I'm going to call it now. Okay, so antacids provide a rapid onset. Antacids, thanks.
No.
Okay, so antacids provide a rapid onset of symptom relief, but their buffering effect is short. So the presence of food in the stomach delays gastric emptying and prolongs the antacid effect. And then antacids are indicated for temporary relief of mild, infrequent heartburn or acid digestion. And you can use the antacids in conjunction with the H2R blockers or the PPIs. So your H2R blockers are your histamine blockers. That's like your Pepcid. They work by reducing gastric hydrochloric acid secretion. They have a slower onset, but they last a lot longer. And then So what they do is they inhibit histamine receptors on the parietal cell. And the onset is usually an hour, but they can last up to 12 hours. And then your proton pump inhibitors, like Prilosec, they inhibit gastric acid secretion by binding to proton pumps in the parietal cell. And acid suppression is dose-related, but it's more prolonged than your H2Rs. So with acute gastritis, we want to eliminate the cause. To help with the full feeling, we want to do 6 small meals a day. Take out anything that's irritating in the diet. If there's nausea and vomiting involved, initially they can be nothing by mouth. We can give them IV fluids, anti-nausea medications. If there's a hemorrhage, we can do an NG tube lavage to suck anything out that's in there. So then here's your meds, your antacids, your histamine blockers, and your proton pump inhibitors. So antacids work by raising the pH. It neutralizes the hydrochloric acid. Like I said, they have a rapid onset, short effect. You want to use these as adjunct therapy with your H2 blockers and your PPIs. And then it recommends empty stomach or after meals for longer effectiveness. And then with the antacid preparations, they just want you to be mindful as a nurse that some of these preparations have magnesium in them, aluminum, calcium carbonate, sodium bicarbonate. So you want to be careful with patients who have liver cirrhosis, hypertension, CHF, or renal disease. And if you also have a patient who's taking digoxin, the antacids can increase the effects of the digoxin. I don't know if that's on here. Oh, no, careful with sodium cardiac patient. There it is. So your histamine blockers decrease your HCl secretion. Slower onset but longer duration. Lasts for up to 12 hours. Your PPIs, like your Prilosec, inhibit HCl secretion. They're more effective than your histamine blockers. Do you guys have any questions? I know that's like a lot.
I think I scared him from asking questions.
I'm going to move on to chronic gastritis. So management of chronic gastritis, you want to evaluate and eliminate the specific cause, which could be, again, aspirin, NSAIDs, alcohol, or H. pylori. So we want to do, again, a non-irritating diet, 6 small meals a day. You'll do antibiotics if it is confirmed H. pylori. Then you've got the anti-secretory agents are your histamine blockers and your PPIs. And then the antacids after meals, vitamin B12 injections if they have anemia, because this is chronic, it's not acute, so it's been going on for a while, so you're going to have those issues with the anemia. Lifestyle changes, and then eliminate smoking. So antibiotics if it's H. pylori, which is amoxil and Biaxin. And then your vitamin B12 injections for anemia. I don't know if that takes it, but yeah, go back. So again, this is gastritis. This is inflammation. You can have acute and chronic. The big thing again with the chronic is that you're going to have the loss of your intrinsic factor.
What's the first antibiotic? The
Amoxil?
So you give antibiotics if H. pylori is present.
Yes.
Is that what you're saying?
Mm-hmm.
And the only way to definitively make that diagnosis is by endoscopy. So they'll scope them. If H. pylori comes positive, then they'll go ahead and treat. Because that's what's causing that irritation.
It progresses acute to chronic if it's not treated properly. So that's how we get chronic.
You probably all have chronic gastritis. Especially right now after the test. Where you all have a blank stare. Because you just purged all the information out.
Okay. You guys okay? Okay. So we're going to move on to peptic ulcer disease. So your peptic ulcer disease is going to be actual erosion of your stomach mucosa. Do you have, I have that picture I wanted to put on here because I don't really, I guess that one's okay, but.
Where? The one you gave me? The one you gave me?
Yeah.
No.
Okay.
Oh, you know, I got it. It's just in my pictures. I take a lot of pictures.
No, that was the pancreas.
Oh, is that the
I
wrong
thought I
one?
sent you the other one.
No.
It's okay.
Okay. Just leave it over there.
Thank you. Sorry.
That's okay.
So any portion of the GI tract that comes in contact with gastric secretions is susceptible. That includes your lower esophagus, which is up there. I can't reach. Your stomach, and then your duodenum, which your duodenum is the start of your small intestine. It affects 10% of males and 4% of women. Those will have an ulcer in their lifetime. It's also seen in children and adults. So again, you have acute and chronic peptic ulcer disease. Acute includes superficial erosion, minimal inflammation, short duration, and resolves quickly. Your chronic peptic ulcer disease is 4 times more common than acute. It lasts longer. It actually can erode through the muscular wall. And then they can last months to lifetime with remissions. And what you want to remember with peptic ulcer disease, so there's gastric and duodenal. Your gastric is always going to be up here in the stomach. Duodenal obviously would be down here in this area. And that'll matter when your patient is describing symptoms to you. We'll go over that. So then you see your acute ulcers in the submucosa, and then your chronic goes all the way down to the muscular layer, and then you'll get scarring as well down there from it, the chronic ulcer. So, peptic ulcer disease depends on degree, duration of mucosal involvement. It's the erosion of the mucosa. And it doesn't matter the amount of acid that's actually secreted, it's the amount of acid that's penetrating into the layers. So your acute is going to be your superficial erosion. Minimal inflammation. Short duration. Resolves quickly. Then your chronic ulcer is going to be longer in duration. And it erodes through your muscular wall, and you have the formation of the scar or fibrous tissue. And the chronic ulcers can last months to a lifetime with remissions.
Could you go over again, I don't understand, the no amount of erosion of the GI mucosa is no amount of acid secreted?
So it's not the amount of acid. So it doesn't matter. You could have like 50 gallons of acid being poured at you. But so it's not how much, but how much that acid can break down the mucosa. Does that make sense? So you can have a small amount of acid that's super concentrated, that's able to really break down the stomach, or you just have the right combination, that perfect storm of underlying factors like personal factors and acid that kind of combine and break it down. So it's not like if you have a lot, you're definitely going to get it, or a little, you won't get it as bad. It has nothing to do with the amount per se, but just how it can penetrate.
The acidity of it.
Or sometimes the acidity of it, or just like because you're more susceptible because you smoke, or because you have H. pylori, or because you have some underlying condition that makes it easier for the acid to penetrate. Sorry.
Thank you. Like I said, chronic ulcers again are 4 times more, peptic ulcers are 4 times more common than your acute peptic ulcers. Okay. So this is on table 4214. And then here again it says it's not the amount of acid that's secreted, but the amount that's able to penetrate through the barrier. And then, so you've got your gastric up here and then your duodenal down here. So again, the gastric is in the body or the fundus of your stomach. And then your duodenal ulcer is going to be in your duodenum, your small intestine, or pylorus, which is the end of the stomach and the opening of the small intestine. Ugh. Did you guys get that? So your gastric ulcers, these are in the body and the fundus of the stomach. They're less common. More frequent in women, unskilled workers, older adults, and smokers. 50 to 70% of these ulcers have H. pylori. They can be caused, again, from meds, aspirin, NSAIDs, corticosteroids. Alcohol and tobacco can also be reasons why you can have a gastric ulcer. Gastric ulcers can also be caused from chronic gastritis, because the chronic gastritis, again, is chronic inflammation. So that can also lead to a gastric ulcer. Ingestion of hot, spicy foods is suggested, but I don't think there's actually any evidence that supports that. Gastric ulcers are less common than duodenal ulcers. And then with gastric ulcers, most of your incidence is going to be in people over 50, so your mortality rate is greater than duodenal ulcers. So with a gastric,
Does this have to do with, like, you're saying hot foods like capsaicin is also prescribed for ulcers?
They think spicy foods because people will complain when they get, when they eat spicy foods that it irritates it, but there's no real evidence. They haven't shown any studies that actually show a correlation
They don't
between
give
it.
capsaicin as a...
I don't know.
Oh, okay.
I don't know that.
I've never
for sure.
heard of it. Capsaicin?
Yeah. Do you know how to spell it?
CAP.
Okay. I can go from there. Yeah. No, I don't think they treat a lot. I don't think they treat the spicy food aspect a lot. And if they do, it's more kind of therapeutic or what's that, like placebo type.
Eliminated from the diet.
Yeah.
That's what I thought was conflicting, because I've heard of the capsaicin being prescribed for ulcers, but I've also been told not to eat spicy foods.
Typically what you do is avoidance. And that's how we tell them. And if it bothers you, don't eat it. But
And a lot of times they use that statement because some people it doesn't seem to bother and
Yes.
they don't have pain afterwards. So if it doesn't bother you, they say go ahead and eat it. But they don't treat prophylactically when you eat spicy foods.
yeah, so I'm not familiar with that because I don't see that.
So with gastric ulcers, your pain is going to be located high in your epigastrium area. It's going to occur spontaneously 1 to 2 hours after a meal. Your pain can be burning or gaseous. I can't even say that word. You can have gas pain. Can occur when your stomach is empty or when food has been ingested. Sometimes there's no pain until there's a complication, or it can cause vomiting. I can't see it there. So, who it affects: women, unskilled workers. This is the gastric ulcer. The older population and smokers.
Unskilled workers?
I don't know if that's just related to
Yeah.
diet
just because
or
they tend to carry those factors that put you at risk. Like they tend to be smokers and they tend to have high stress levels and they tend to have poor diets that put them at risk. Plus, I'm blanking on what I want to say.
do you,
But and then just increased risk for H. pylori. So.
and again, so gastric ulcers, you'll see H. pylori 50 to 70% of the time. Again, can be caused by medications, alcohol, and tobacco. And these are less common than duodenal ulcers. So, clinical manifestations of gastric ulcer. Your pain's gonna be high in your epigastric area because it's a stomach ulcer. Spontaneously 1 to 2 hours after a meal. Can have a gas-like feeling or burning feeling. Bless you. Can be associated with vomiting. And then if the ulcer's eroded, food can aggravate. So So your gastric ulcers are more likely to result in hemorrhage, perforations, and obstruction, which is later in the presentation. We'll go over those. Am I going too slow now? Because I know I was going really fast. Are you guys
This is
okay?
better pace.
Okay.
You're doing great.
Thanks. Okay. All right, so your duodenal ulcers. So these are going to be lower down, either in the pylorus or the duodenum, which is your small intestine. And 80% of peptic ulcers are duodenal ulcers. They affect more men between the ages of 35 and 45 years old. They're associated with a high hydrochloric acid secretion, which is usually from alcohol and tobacco. And then with the duodenal ulcers, H. pylori is found in 90 to 95% of the cases. And there's a possible genetic link. So your pain is going to be in your mid-epigastric area beneath your xiphoid process. This pain is going to be 2 to 4 hours after a meal, most likely because it's going to be lower, in a lower area than your gastric would be. Your pain can be burning or cramp-like. You can have back pain. These can be relieved by antacids alone, or you can take them with histamine blockers, the antacids with histamine blockers. And these can be relieved by foods that neutralize the hydrochloric acid. Your duodenal ulcers occur continuously for a few months and they disappear for a time and then come back. May have no pain, you can have vomiting. Do you know why symptoms are worse in spring and fall? Okay, I didn't, you didn't either.
Are we gonna have to know any foods that are,
With all of these diseases, you're gonna wanna think about diet.
Yeah, just in general, not like specific.
Right. Particularly those things that are causative factors, like ulcers, gastric ulcers, and smoking and coffee.
Okay, duodenal. So again, you find these ulcers in men 35 to 45 years of age. You have an increase in the hydrochloric acid secretion. Alcohol and tobacco are causes. And H. pylori accounts for 90 to 95% in these ulcers, the duodenal ulcers. Your clinical manifestations of a duodenal ulcer: mid-epigastric pain, and it's going to be 2 to 4 hours after a meal because it's lower. You can have burning, cramping, back pain. Can be relieved by food which neutralizes the hydrochloric acid. Relieved by antacids and a combination with histamine blockers. Ah.
So you guys see, like, imagine you just ate the candy that I gave you. If you look at the clinical manifestations to kind of compare the two, if you actually took your little candy, what's it gonna hit first? gastric, right? So you're gonna have pain first, it's high up, so you're gonna have pain way up here, and you're gonna get it pretty soon after you eat that candy. But then it takes the candy a while, because it sits here and turns all, I'm probably scratching. Don't tell. It turns all around, and then it comes and hits the duodenal ulcer, right? So that's going to be a little bit lower. It's going to be a few hours later because it takes a while to get down there. So when you're looking at the two ulcers, remember kind of where they are and where they're situated, because that's when you're going to start seeing symptoms. So if a patient come in and they're like, right after I eat, then I'm getting this pain and burning and I feel like I'm going to throw up, you know, oh, okay, I'm thinking gastric. Or if they're like, I eat and I'm fine, but then like a couple hours later, I just feel like crap and I feel this burning and it feels gross. And then I eat again and it feels better. So, does that make sense? So when you're looking at the two, kind of think of where they are and when food's hitting it. And that kind of makes a difference for it. Does anybody need a piece of candy?
I'll scratch that now.
I know. Well, now I probably scratched that. Don't touch chocolate.
Don't want.
So how do we diagnose these ulcers? We do a history and physical, meds, lifestyle, and then again you do the upper GI endoscopy with a biopsy to test for H. pylori. You can do serum testing for IgG. The serum testing doesn't let you know if it's an active infection though with the IgG. I didn't know you were right behind. That's okay.
I was just gonna say, if you want, just skip ahead so that they can write while you're explaining,
okay.
and it will slow you down. Does that make sense?
Yes. Okay. You've also got H. pylori testing of the breath, urine, blood, and tissue. There it is. You can do a gastric analysis to check for the levels of hydrochloric acid. And then they can do barium contrast studies, upper GI barium contrast studies. And then your lab studies would include a CBC to check for anemia secondary to bleeding. Sometimes they'll check your LFTs just to check if there's any liver problems, such as cirrhosis, which could complicate the treatment of an ulcer. They can check the urine and stool for blood. And then they'll also sometimes check a serum amylase, which is actually checking the pancreatic function due to possible posterior duodenal penetration of the pancreas. And x-rays are not helpful with these kind of ulcers either, with peptic ulcers.
I'm sorry. How does the barium contrast work? I have no idea.
That's when you swallow the barium, and I don't know if it'll go around the ulcer and you can see the ulcer. So it's a barium that you swallow, and then it's kind of cool. You can watch on a screen. And does it fill it or does it go around it because it's so acidic? I can't remember.
I don't know exactly how, like, if it goes into the ulcer itself or goes around it.
It goes around
But
it.
think of like a white chalk you swallow, and it's radioactive. So when they do x-rays or they do a CAT scan, they can actually sit there and take pictures, and they can watch it go through the GI system and actually go throughout the entire body.
So it highlights.
It highlights the areas that there's wrong, and I don't know if it highlights it because it misses it or
Right.
highlights it because it goes
'Cause
into
it goes
it,
in.
but it basically highlights the, I don't want to say defective, but broken down area or diseased area, whatever.
Thank you.
Mm-hmm.
Okay. So your collaborative care. Let's go over here. So we want to reduce the degree of gastric acidity, enhance mucosal defense mechanism. We want to rest and decrease our stress, physical and emotional stress. 6 small meals a day, non-irritating or bland. We want to avoid alcohol, caffeine, foods that are high in roughage that are hard to digest. No smoking. No aspirin or NSAIDs. We want to use our histamine blockers and our PPIs. And if you've got H. pylori, we want to use antibiotics with PPIs. Again, there's your amoxil and your Biaxin. So with your ulcers, your pain can disappear 3 to 6 days after starting therapy, but the actual healing can take up to 3 to 9 weeks. So we just want to make sure that we're teaching just because the pain goes away. We don't want to stop the therapy until it's completed. And I think they want you to know you guys shouldn't be interchanging brands. It should be the same brand that's continuously used while you're treating the ulcer. And then there's also, it's not on here, they're called cytoprotective drugs. That's like your Carafate that you take before a meal, and it basically just coats your esophagus and stomach and duodenum, and it helps accelerate ulcer healing. And that was called Carafate. I don't know if that's on there. Okay. So then here's the complications of chronic peptic ulcers, and then just go straight to here. So you've got hemorrhage, which is your most common complication, and this develops from erosion of the granulation tissue. Duodenal ulcers account for a greater percentage of upper GI bleeding than the gastric ulcers do. Sometimes with the bleeding, you'll want to be careful because the patient's pain will decrease because blood neutralizes the acidic gastric contents. So most common in the duodenal ulcers. Erosion of granulation tissue through the blood vessel. All right, your perforations are going to be your most lethal complication. So these are commonly seen in large penetrating duodenal ulcers that haven't healed, or they're going to be located on the posterior, the back of the mucosal wall. You can also have perforated gastric ulcers that are most often on the lesser curvature of the stomach. Your mortality with the perforation of gastric ulcers is higher. I'm going to go with usually that's because the older population is the ones who have the gastric ulcers. So your ulcer, either one penetrates your serosal surface, and then the gastric contents are spilled into your peritoneal cavity. And then there's a huge red star by your signs and symptoms. So we'll go over those. So your clinical manifestations with a perforation are going to be sudden and dramatic. You're going to have severe upper abdominal pain that quickly spreads through the abdomen. You can have shoulder pain. Your abdominal muscles are going to contract. They're going to look rigid and board-like. Your respirations for your patient are going to be shallow and rapid. Bowel sounds are probably going to be absent. You can have nausea, vomiting. And a lot of patients that end up with perforation have a history of ulcer disease or recent symptoms of indigestion. So there's your sudden, acute, severe pain, rigid abdomen, no bowel sounds, nausea, vomiting. shallow respirations, tachycardic, weak pulse. And then you want to assess their abdomen and their vital signs. And then you also have the complication of a gastric outlet obstruction. The outlet obstructions usually happen when the ulcer is close to the pylorus, which is right here. So if you have an ulcer right here that's inflamed, you can see how it's going to kind of block anything coming from down in the stomach. So in the early phase, gastric emptying is normal to near normal. But when your stomach is trying to push things through, you get an increased force, and over time, it results in hypertrophy of the stomach wall. So you're losing your tone, your ability to move everything down, which results in a narrowing of the pylorus. Outlet obstructions have a long history of ulcer pain progressing from generalized to upper abdominal discomfort. Your pain with an obstruction, an outlet obstruction, is going to be worse towards the end of the day as the stomach fills and dilates. Patients get relief by belching and vomiting. The vomit will sometimes contain food particles that were ingested hours ago or even a day or two before. And then the dilation of the stomach can cause a swelling in the upper abdomen. So these are less common. Edema, inflammation causes a blockage. And then relief with belching and then the vomiting of undigested food. Where it goes from here. So your management of complications. How are we going to treat these? We can do NG for suction, IV fluids, your lactated ringers, and your albumin. Your lactated ringers help substitute for fluid loss from the vascular and interstitial space. We'll give blood if, their hemoglobin drops from bleeding. They can do surgical repair. The surgical therapy is actually on page 949 in your Lewis book. Perforations, they can do an open or lap procedure, and then usually they'll do antibiotics just because of the spillage of the contents. Gastric outlet, you're going to want to definitely decompress the stomach, so you'll use the NG tube. Give me a second. And then you've got one more little ulcer, your physiologic stress ulcer. So these are acute ulcers that follow a major physiologic insult after trauma or surgery. Sorry, she snuck it down over there in the corner.
You didn't think I was gonna let that big square of space go on, did you?
They're common in infancy and childhood. You can prevent these with your H2Rs and your PPIs prophylactically, which means before they happen. So there's your H2s and your PPIs. Oop. And then, do you want, I'm going to stop there, Dr. Daniels, because
Yeah.
now I'm on the pancreas.
Yep.
Okay.
All right. So you guys have any questions regarding that?
This is one we see in our major trauma victims
Yeah.
because they're under tremendous physiological. So we always start these medications prophylactically.
And every single one of your patients you have probably seen is on an H2 blocker or proton pump inhibitor,
Yeah.
just because of that physiological stress. And when they're in the hospital, I should say. All right, when we come back, we're gonna we have half hour for lunch. So we'll be back at 12:15, and then, oh, I'm sorry. We'll be back at 12:15 for that, and we're gonna finish up with,